I am proud to introduce Professor Dilip R. Yavagal, Professor of Clinical Neurology and Neurosurgery, Director of Interventional Neurology, Co-Director Endovascular Neurosurgery, and Director Neurological Platform Interdisciplinary Stem Cell, University of Miami Miller School of Medicine. One of the brilliant students of Sage GS Medical College, Mumbai. He has an abridged CV running for 35 pages. A man of great achievements and an authority in thrombectomies and stroke management. We are very lucky to have him amongst us for educating us about thrombectomies in COVID patients. How safe is it? How different is it? And the salient features in the management of thrombotic strokes, especially with regards to the COVID patients. Audience can type their questions in the chat section of the YouTube channel and the speakers will answer their questions at the end of the session. Over to you, sir. We welcome you.
Thank you so much, Dr. Srivajayan and the chairpersons, Dr. Ramchandran, my dear friend. Thank you for this wonderful opportunity to speak to this fantastic audience. It's always a pleasure to connect with India and connect with Ram whenever I get the opportunity. This is a unprecedented time for all of us, and what I'd like to share is a very important topic of the management of severe stroke that actually has taken even more importance during this pandemic. The safety and efficacy of mechanical thrombectomy for acute ischemic stroke patients in COVID-19. These are my disclosures. I don't have any royalties or any stock ownership in the devices that are used. I do consult for companies. So what I'd like to do is start with a overview of why COVID-19 leads to a increased risk of stroke. And this is related to the hypercoagulable state that COVID-19 causes. And what have we found in our studies in COVID-19 is something that I'd like to share with you from our own research and others. And then also talk about the large vessel occlusion subtype of stroke, which is quite common in COVID-19. And then the treatment, which is now the new standard of care, called mechanical thrombectomy, which is overwhelmingly effective in reversing stroke paralysis. I'd like to discuss the scientific evidence and then also really show you some cases where we've done mechanical thrombectomy in COVID-19 patients and other colleagues of mine. And hopefully we can all take some very important take-home points home for management of stroke, especially during COVID-19. These are my colleagues at the University of Miami who I am very grateful to. We run a large stroke service here, along with two consultants who are partners of mine in neurointervention, who are both neurosurgeons, and then I'm the interventional neurologist. And then we have a 10-member stroke consultant team that help us manage these patients, and then two fellows who are doing a 2-year fellowships to learn the neurointerventional techniques for treatment of neurovascular diseases. So what we have quickly come to know, as the previous speaker mentioned, is a lot of knowledge about what COVID-19 does to the human body. What is become clear is that the several mechanisms of injury, including cytokine storms, including the ACE2 receptor that is activated, and the D-dimers that are increased, they all seem to ultimately lead to a increased thrombogenicity or a hypercoagulable state. And this clearly increases the risk of acute ischemic stroke, which is a sudden thromboembolic phenomena majority of the times. We also get the same final common pathway from the systemic syndrome that COVID-19 causes, including sepsis and DIC. So what has really come to the fore is that the effect of COVID-19 is not just the well-recognized pneumonia and respiratory distress syndrome, but really a silent but very lethal hypercoagulable state that is caused by COVID-19. And this leads to not just stroke, but also to MI, to limb ischemia. And so we are getting clearly increasing amounts of data showing that COVID-19 leads to thrombotic events at a much higher rate than usual. So here is a case example. This is a 48-year-old gentleman who had no past medical history. He collapsed while walking. This is from a colleague of mine in New Jersey, which is a hot spot. He was brought by the emergency medical services, the ambulance service that is uniform throughout the United States. It can be called by a single number throughout the country, 911. They came within just a few minutes of calling, just about 9 minutes, and he was found to have a right-sided weakness, and he was unable to speak. He was brought to the primary stroke center first, where the nearest primary stroke center, where intravenous TPA was given after a head CT ruled out a bleed, and then a CT angiogram showed that the left M1 was occluded. He was transferred for thrombectomy to a higher level stroke center called a thrombectomy stroke center within 1 hour from the primary stroke center. He reported no recent respiratory symptoms, fevers, or chills, but he was COVID positive on the rapid COVID antigen test in the ED. What you see here is that the head CT is actually fairly unremarkable, and this is now about 2.5 hours from stroke symptom onset. And it's pretty common that the head CT is unremarkable. This is the hemisphere of interest, and we hardly see any early ischemic changes, maybe some early hypodensities here. But the CT angiogram shows a clear cutoff of the left M1. You can see the right MCA is quite nice, but the left M1 is cut off. So we know that from his left hemispheric syndrome and the CTA showing a cutoff, that indeed the stroke is coming from a blockage of the left middle cerebral artery, the first segment called the M1 segment. The patient also on the CT angiogram showed what's called a filling defect in the carotid in the neck. And so this is actually quite common, that there are multiple sites of clotting that occur in the cerebral cervical tree in COVID-19 patients. Again, the result of a hypercoagulable state. He was brought to the angiography suite for thrombectomy at the thrombectomy stroke center, and you can see the contrast stops right here because of the clot that's present, and we are starting to put what is called a stent retriever and aspiration catheter into the clot. I will actually finish the story of the patient later on, but this brings us, and you can see that the M1 is also occluded on angiogram. So this is the cervical ICA that goes up all the way, and this is after that clot was removed, and you can see the next blockage was in the M1. So this is a classic COVID-19 patient having a stroke with multiple sites of clotting on one side. What we know in non-COVID patients since 2015 from 8 randomized controlled trials is that when we find patients having a large artery blocked, also called large vessel occlusion, and presenting with stroke symptoms, we now have the ability to treat them very effectively with mechanical thrombectomy. This is a non-COVID patient from before the COVID era who came to me in 2015. She was 26, healthy. She was having breakfast with her boyfriend and suddenly started to drop things from her right-hand side and started to have difficulty with her speech. And what you can see is when she was abroad and the CT scan was negative for bleeding, the CT angiogram showed a left arm occlusion. The angiogram indeed shows that the left ICA comes up and then it suddenly stops at the first segment of the middle cerebral artery. This is the anterior cerebral artery that continues to fill. When you look at the lateral angiogram, this is the cervical ICA that goes and becomes intracranial, and then it bifurcates, and the ACA is filling, but there are no MCA branches, only the temporal branch here that's filling. This is the posterior communicating artery, but all the branches of the MCA are absent. In this case, we went up right away with the mechanical thrombectomy system called a stent retriever. What we do in this procedure is we go up with a guide catheter in the cervical carotid and bring up a 14,000th of an inch wire into the blocked artery and cross the thrombus with that 14,000th of an inch wire very safely, very swiftly. And then we bring up a microcatheter over the wire that allows us to then bring what is called a stent retriever device. This device helps us to actually engage the clot, and you'll see in a second how that happens. But this was found serendipitously that a stent-like structure actually is a great way of engaging the clot, and the clot actually gets engaged on the outer surface of this stent that is used as a retriever. And so what you see is that the stent pushes the clot aside. There's actually now blood flow, but the stent has the clot caught onto it on the outside surface. We wait for a few minutes, typically about 5 minutes, and then we start to retrieve both the stent and the clot, thus opening the artery. We inflate the balloon at the end of the catheter in the neck to prevent and the blood from pushing the clot away, the blood flow from pushing the clot away, and you can see that the clot is brought out with the stent into the guide catheter and then outside the body. This is the picture of how the stent engages the clot on its outer surface. And this was the clot that I brought out in this young patient. You can see it's all caught in the stent struts outside, and we have now a complete opening of the artery, and all the branches of the MCA are open. She started to recover speech on the table very dramatically, started to talk to us, and then she started to lift her right side, and she was back to normal the next day and discharged. You can see that this kind of dramatic outcome is really something that's a big advance in stroke treatment. This is a 63-year-old patient, so much older, who came within 2 hours of a right MCA syndrome. She was weak on the left side, and you can see that except for this area where the gray-white differentiation is somewhat blurred, you can see it's clear here, the gray-white differentiation, but the gray-white differentiation is blurred here. The rest of the hemisphere looks very good. Her stroke score was 8 on a scale of 0 to 42. She could not be given TPA because she had been on Coumadin. She really went for a thrombectomy, and I think I'm missing those slides with, again, a very good outcome. What we saw in 2015 is that there were 6 trials that occurred around the globe, randomized controlled trials, that all showed us that these great results are not just a one-off, but are truly a new therapy that's very powerful. What it showed in these trials was that when patients were treated with mechanical thrombectomy, their chance of being independent, that is modified Rankin scale of 0 to 2, at 3 months was significantly higher in each and every trial as compared to control patients who did not get mechanical thrombectomy. They either received IV TPA, most of them received IV TPA, and regular medical therapy, but not thrombectomy. And every trial that was ongoing at that time showed that mechanical thrombectomy was significantly superior in making the patients independent at 90 days. When you look at these numbers, these are again very telling that the first trial that was published had a 31% chance of the patient being independent if they were treated with mechanical thrombectomy, and only 19% if they were not. And this percentage actually kept going on higher as the trial designs were superior. And the adverse effect of symptomatic hemorrhage was actually no different in the two arms. It was about 6%, as high as 6%, and as low as only 1% in the thrombectomy arm, and it was not any different from the non-thrombectomy arm. What that resulted in with this efficacy was that the number needed to treat to get one independent patient was as low as 3 in the Extend IA trial, which is done from Australia. So highly beneficial treatment with a very low adverse event rate for how serious the condition that we are treating with this procedure.